Yeah, thank you, Sachin, for the kind introduction. Uh, just share my screen. Okay, my screen is visible, Sachin? Hello? Visible. Okay, sure. Okay. So, good evening, everyone. And today I have the opportunity to speak on a very interesting topic. I'm going to speak on the one oral antidiabetic that I use the most. Okay, and the hint you get is from the brushes given below. Now, at the end of the lecture, you will tell me why, what the brush has relevance to do with this topic. There are two or three reasons where the brush kind of fits with the topic, but you will tell me why. So, I'm going to talk to you about one oral antidiabetic that I use the most, and I'll show you some clinical cases. I'll show you some clinical scenarios where I use this the most. And again, not to, I'm sure all of you are aware, the answer actually is Acarbose. This is the one oral antidiabetic that is there in almost every prescription of mine, irrespective of the type of diabetes which the patient has. So we are going to discuss about Acarbose in detail, right from the mechanism of action to, we'll discuss a little bit of concepts about time in range, and then we'll see how I use Acarbose in my practice and also some interesting cases. So how does Acarbose really work? Now, Acarbose comes from a family of drugs called alpha glucosidase inhibitor, AGI. AGIs are very popular in South Asian countries, China, India, and many other South Asian countries. The reason is that all of us take a lot of heavy carbohydrate meal. In fact, one of the most fastest selling oral antidiabetic drug in China, apart from India, where the diet also is very similar, rich in carbohydrate. Now, why hence Acarbose is very important for diet similar to that of Chinese and that of Indian. Now, we all know that when you eat a carbohydrate, you eat a carbohydrate in various forms. You could eat a glucose, right? This is a monosaccharide. You could eat something like a sucrose, which is a disaccharide, or you could eat a oligosaccharide like a starch, right? Or you could have a complex carbohydrate. So there are various forms of carbohydrates that you take. Now, whatever form of carbohydrate that you take ultimately gets broken down into simple carbohydrate, that is glucose, and this glucose is the one which is absorbed from the intestine. So, Acarbose basically acts on two very important enzymes. It acts on the amylase, alpha amylase, which is there in the oral saliva, and it acts on the alpha glucosidase, which is an enzyme which is found in the brush border of the intestines. So, hence the brush. Okay. So, in both the situation, these enzymes, they break down the complex carbohydrate, that is either oligosaccharide, as in case of alpha glucosidase, or alpha amylase breaks down a polysaccharide into simple carbohydrates, and this process is inhibited by Acarbose. So this breaking down of breaking down of complex carbohydrates into simple carbohydrates, that is glucose, is blocked by Acarbose, and because it is blocked by Acarbose, it prevents the absorption of glucose, and this prevention of glucose absorption is what is the clinical benefit that you see in clinical practice. So you can see here the same thing in the intestine. So the brush border of the small intestine, where in a normal situation, these oligosaccharides and polysaccharides are broken down by alpha glucosidase into monosaccharides, and these monosaccharides are absorbed. But when you use an Acarbose, what it does is it blocks this alpha glucosidase, and hence it prevents the complex carbohydrate into breaking down into monosaccharides, and hence prevents the absorption, and hence prevents the postprandial hyperglycemia. Remember, this is a drug which mainly acts on the postprandial system. So if you can classify drugs that act on fasting glucose and postprandial glucose, right? So what drugs act on fasting? So you have metformin, typically acts on fasting blood glucose, even to some extent pioglitazone. Then you have basal insulin, long-acting SUs. These are all drugs, long-acting GLP-1, right? These are all drugs which act on fasting glucose. There are some drugs which act on both, we'll discuss that. Whereas postprandial, mainly AGIs, that is alpha glucosidase inhibitors, they act on postprandial glucose. Short-acting SUs, short acting insulin or rapidly acting insulin, right? Short acting GLP-1 RA. These are all agents which act on postprandial glucose and very popular DPP-4 inhibitors. Okay, all these drugs act on postprandial glucose. Something like an SGLT2 inhibitor acts on both fasting and postprandial, but it has different ways in which it acts on both. And GLP-1 RA, especially long-acting ones, act on both, right? So there are certain drugs which act on both, but mainly if you see, metformin is one of the chief drug that acts on fasting, and AGI is one of the oldest and the chief drug that acts on postprandial, right? So this is one clear definition. So if you have a patient and you start the patient on a metformin with Acarbose combination, you actually cover the first line of both the situation, fasting and postprandial, right? So this is how you typically do it, right? Now, how is Acarbose typically given? Acarbose is typically given in doses starting from 25 milligram. You can go up to then 50 and up to 100 milligram. It is given 3 times a day. It is given immediately before meals. Now, you can give it in two ways. Either the patient can chew the tablet just before the meal, or you can swallow it. The difference is actually this, that when you chew the tablet, okay, remember it also acts on the alpha amylase in the oral cavity, right, in the saliva. So this alpha amylase activity benefit you get when the patient chews the tablet. So if the patient chews the tablet, he gets the benefit of the alpha amylase blocking also. Whereas if the patient swallows the tablet, it mainly acts on the brush border of the intestine, and that is where its main action really lies. So alpha glucosidase inhibitors, or Acarbose especially, is the most versatile oral antidiabetic drug. It can be used in variety of situations. In fact, it can be used in any form of diabetes. It is of course approved for use in type 2. It is also approved for use in type 1 in India. It can be used in pancreatic diabetes, so you have to be careful as far as the GI side effects are concerned here. It can be used in hypoglycemia in pregnancy, right? So it can be used in that situation also. It also can be used in hypoglycemic syndromes. We'll discuss this in the end. So it can be used in post-prandial syndrome or reactive hypoglycemia. It can be used in post-bariatric hypoglycemia. It can be used in a condition called NIPHS or adult onset neseidoblastosis. So these are all conditions where Acarbose can be widely used. Now, before we go ahead with the concept of what Acarbose does in terms of benefit to the patient, let us discuss a little bit of concept of the glycemic variability. Now, if you see the holy grail or the 3 steps in diabetes management, we all want these things to be under control. So that is fasting and postprandial glucose we want under control. We want the HbA1c under control, and we want the glycemic variability to be low, right? So these are the holy trinity of the diabetes management. So you want all the 3 conditions to be good, right? So you want the individual sugar levels to be fine, you want the HbA1c to be under control, you also want glycemic variability to be less. So if you are able to do all the 3 situations, then you are in a situation where patient's overall glycemic control is very good. Okay, so this is how you ultimately balance out all the 3 things. Now let's look at some examples of glycemic variability. Okay, let us understand glycemic variability from an example point of view. So you have, yeah, I think just you will have to give me 1 second. I hope the screen is visible again. Yeah, okay, sorry for that. So let's look at the glycemic variability from a CGM perspective. So this is a patient of mine, you can see, and here you can see a AGP, that is a ambulatory glucose profile of this patient using a Libre Pro CGM. So what you see here is, you can see the markings on the top, right? These markings on the top are the average glucose values in the various time frames, right? So during the day, and what you see is the thickness of the graph. that is on various days how the sugars are trending, right? So for example, at let's say 8 o'clock, right, on different days, you can see the thickness. On one day it will be little, maybe high, little bit low, right? So on and so forth. So what you see in this patient is that this patient generally has a low glycemic variability. So if you see throughout the day, right, if you see throughout the day, his sugars are minimum is 99, maximum it goes to somewhere around 190, right? So that's the range which the patient is trending within. So within the day, inter-day glycemic variability is not that high. And if you see intraday glycemic variability on different days also, that is from the thickness of the graph. The thickness of the graph is also not much, right? So it's a more or less, thickness is very less. So again, this patient technically has a low glycemic variability. If you see the average glucose, it's 144 in this patient. But let me show you another patient, patient number 2. The patient again has average glucose same, average is same. So if you do HbA1c of both the patients, HbA1c is going to come to be very similar values, right? So HbA1c is going to come similar, but this patient, you can see from the CGM itself, the difference is very large, right? So you can see within the day, lowest sugars are 93 average and highest are 205. So the difference is large. But if you see on various days, that is intraday, you can see, or rather interday on various days, you can see the glycemic variability, the thickness of the graph is very, very large. Okay. So on some days, for example, if you see here, some days the patient at 8 o'clock is having hypoglycemia, and some days the sugars are almost close to 200. So this patient, though having good average and good HbA1c, the glycemic variability is very, very profound. So this patient is not going to do very well on a long-term basis. This patient is going to have a lot of diabetes-related complications, whereas this patient will have relatively less diabetes complication. And you see the third patient here, right? The third patient is having extremely good, so interday and intraday glycemic variability is very less. So within the day also, intraday, right, minimum is around 96, maximum is 140, right? So not much. And again, interday also, the thickness of the graph you can see is very, very thin, right? So he's having a very, very stable glucose value. So this type of patient generally is going to do very well on a long-term basis, right? So again, glycemic variability can be short-term or intraday glycemic variability, or it could be medium-term, that is interday glycemic variability, or it could be long-term, that is long-term glycemic variability. You are looking at, like the long-term, BSc, NSC charts. Long-term is basically what you see is the HbA1c changes that happen over a period of time. Now, how do you measure glycemic variability? So glycemic variability can be measured by something called a standard deviation, that is how much deviation happens from the mean. This is again a mathematical formula. Again, some CGM matrix gives you this formula. You can use coefficient of variation, that is standard deviation divided by mean into 100, right? And this is considered the best indicator of intraday glycemic variation. And value more than 36% is considered to be high glycemic variability. So again, if you see these values of these 3 patients, you can see the standard deviation is actually not very different. But the normal should be 17 plus minus 3. That should be the normal range of standard. But you can see standard deviation a little high on all these parameters. But if you see the coefficient of variation, where you are actually dividing that by mean, you can see the third patient is doing very well, and you can see the middle patient is not doing very well, right? So the the coefficient of variation is actually high. Okay. So this is where ultimately you have to understand the concept of glycemic variability. Now, to tell you how Acarbose actually reduces glycemic variability, I am going to show you just one example, and that example is very, very clear to show you how profound AGI is in terms of reduction of glycemic variability. Just one example to give you. We had this patient, right? As you can see the dates here. It's an old case, right? So September 2022, 4th September to 18th September 2020, right? This is the CGM profile. Patient actually was complaining of vague symptoms in the morning. He was saying that he had morning headaches, and we thought that patient is probably having hypoglycemia. In fact, when he used to wake up in the morning, check the sugars, it used to be around 110. But then he used to wake up with a headache, right? So he was also thinking that there is something going wrong at night. So that's why he put the CGM on this patient. And when he put the CGM, he was actually right. We are also right. Patient was having nighttime hypoglycemia. Okay. Now, also something very interesting. So this patient had an HbA1c of around 6.4%, very good HbA1c. So he was very happy with the glycemic control. But having said that, there was still some residual issue. And again, when we saw this patient's CGM, you can see post meals, every time patient is having these type of peaks, right? So post breakfast is having a peak, post lunch is having a peak, post dinner is having a peak, right? So there are small peaks which happen post meal. So what we did was, this patient was on a sulfonylurea plus metformin with a pioglitazone. So we reduced the sulfonylurea, in fact changed from glimepiride to gliclazide, continued the metformin, reduced the dose of pioglitazone and put the patient on Acarbose 3 times a day. And you can see this remarkable, this is before, this is with AGI, remarkable flattening of the curve. Not only is the hyperglycemia reduced, but the hypoglycemia is also gone. So this patient now has a absolutely stable glycemic control without producing hypoglycemia. And you can see the dates, right? This was September and this is in October where we put the CGM again for this patient, and you can see the remarkable change in terms of reduction of glycemia. This is the most classic example of reduction of glycemic variability that you can see, right? So this is to illustrate to you a point how important glycemic variability is. We in fact did a study also. We have not published this data, but I'll show you our own data on glycemic variability. We're actually doing a study called FFF study where we are looking at fixed fasting first. What we are trying to see is that once you control the fasting of the patient, and then we used to put the CGM and we used to see whether just fixing the fasting is enough to get overall good glycemic control. Now, this was we took the data of about 40 patients where the mean HbA1c was 10, right? Which was high, of course, and it's a tertiary referral center, so we'll get more complicated patients. When you see our prescriptions, we actually prescribe 100% of the patient, we prescribe Acarbose. You can see this. In fact, we did not even prescribe metformin 100% of patient, but Acarbose was prescribed in 100% of patient. A lot of these patients, because they were on, the idea was to actually look at fixed fasting, and hence a lot of patients had HbA1c also high. A lot of patients were on insulin actually, right? But if you see the glycemic parameters, remember we are using Acarbose is 100% of the patient, and our own data, the time in range, right, should be more than 70%. It was 77% in our study. Average glucose was very good. This is after treatment. And glucose management index, you can see the standard deviation, which should be less than 36, was 34, and coefficient of variation also less than 36% was 30%. So you can see we are doing very well in terms of overall glycemic control, right? Then let me show you some cases, okay, just real life cases to illustrate this point. So let's look at a couple of cases of type 2 diabetes. So this is a 46-year-old patient who was taking some naturopathic treatment for diabetes. His HbA1c was 10.5. He was having weight loss. Fasting sugar was 230. Post meal was 313. So what we did, we started the patient on basal insulin, Acarbose 3 times a day, metformin and DPP-4 inhibitor, right? And with Acarbose, with basal insulin, we titrated the basal insulin to achieve fixed fasting first. This was the idea, right? So we started with this. We typically titrate the basal insulin to achieve the fasting in target range, right? And then we look at the AGP, which all typically controls the postprandial sugar. And once we achieve the fasting sugar, we put the CGM you look at the chart. And if you see this patient, you can see the chart. This is an old case again, 2018. So started with fasting of 250. Insulin dose was 20. We gradually increased the insulin dose. Final dose came to 38 units with the fasting glucose of 116, right? And you can see the trend here, and then after that we put the CGM, and you can see the remarkable CGM, right? So the glucose management index is pretty good, and you can see the overall glycemic control. This is the target range, right? Most of the sugars are very well controlled. Of course, there are still some peaks, right? So we can actually increase the dose of Acarbose over here, right, to reduce this also, but it is quite possible. But having said that, we are able to achieve a very good glycemic control with just fixed fasting first. So another case similar, right, with type 2 diabetes, again we did the similar process, and again we are able to achieve excellent glycemic control, right? Now, so these are all cases where in typical type 2 diabetes patients where Acarbose becomes very effective. Let's look at some other conditions where Acarbose will work. So apart from type 2, it can be used in pancreatic diabetes, it can be used in type 1 diabetes, it can be used in hypoglycemia in pregnancy also. In pregnancy, it is category B, which is same as metformin, right? So it is as safe or as safe as metformin. So if you are using metformin, you can very well use Acarbose also. In fact, Acarbose is better than metformin in this situation because remember in pregnancy, the postprandial hyperglycemia is a major challenge. Let's look at a couple of cases of pancreatic diabetes. So this is a 40-year-old patient with chronic pancreatitis with exocrine and endocrine insufficiency on basal bolus insulin with poor glycemic control, and we switched to basal bolus with Acarbose. So again, we titrated the basal insulin, and then with the AGP we titrated the bolus also. and you can see the glycemic control. Now, of course, you can see a lot of glycemic variability, right? Remember, pancreatic patients will have a lot of glycemic variability, but reasonably we're able to do well overall, right? So another patient, 45-year-old with chronic pancreatitis with exocrine insufficiency, recently diagnosed with endocrine problems. HbA1c was 14, blood glucose was 400. We put the patient on basal plus acarbose, fixed the fasting first. We did not put the patient on, any other drug, right? Just acarbose and basal insulin with a idea of probably adding a short-acting insulin if required. And again, with this alone also, we are able to achieve excellent glycemic control in this patient. You can see, in fact, flatter, right? So I have this general principle: the less moving parts you have, the better control you achieve. So we just looked at the patient's sugar. We just see short that if you need short-acting, then we'll add, right? So that is what we did. Now, another very interesting thing about acarbose is that actually it can be used in hypoglycemia also. Now, this is very interesting, right? In fact, patients having postprandial hypoglycemia. So, acarbose, as we discussed, it is very popular to be used in something called a reactive hypoglycemia. I'll show you a case of that, published case of that, not ours, someone else's. It can be used in post-bariatric hypoglycemia. So, any condition where you have postprandial hypoglycemia, you can use acarbose. It is very, very effective in these situations, right? Now, this is a published case where they looked at this situation where they used acarbose in a patient with reactive hypoglycemia. What is reactive hypoglycemia? Reactive hypoglycemia is, you would have seen patients where, patient has post-meal hypoglycemia. There are a lot of patients like this. Now, why does this happen? In which kind of patients this happens? This mainly happens in it happens in pre-diabetic patients or very early diabetic patients. So why this happens is that, remember, in especially Indian patients, right? Remember, insulin is released in two phases in all, of course, everybody. First phase, insulin secretion, and then there is a second phase of insulin secretion, right? Now, in Indian patients especially, this first phase insulin secretion is blunted and it is delayed. Okay, so this is a normal. In a normal patient, person without diabetes or without any kind of pancreatic issue, this patient will have first phase and then second phase insulin secretion. This is a normal insulin response. But what happens is, when you start losing the first phase insulin secretion, especially like in Indian patients, sometimes what happens, this first phase insulin secretion is flattened and delayed, and this is what happens, right? So this is what happens in Indian early diabetics. Okay, so this is a very typical profile that you see in patients, right? Now, what happens is something like this, right? That when such patients, right, they eat carbohydrate, right? So I'll show you what happens. So let's say this is the glucose curve, right? So this is the curve for glucose, okay? So when you're eating a carbohydrate, the glucose levels goes up, right? And then glucose levels come down, okay? So in a normal situation, when the glucose levels start going up, the insulin levels also go up, and insulin levels also start coming down with so it matches. But in certain patients, like the patients where there is a delayed first phase insulin secretion, the glucose levels goes up, right? But the insulin secretion is delayed. Because insulin secretion is delayed, this is what happens, right? Now, here what is happening is, when the glucose level is coming down, the insulin level is going up, right? And that's why this is a point where the patient will develop hypoglycemia. Right? So glucose is coming down, but the insulin is still high. And because of this mismatch, these patients develop what is known as reactive hypoglycemia or postprandial hypoglycemia. Right? Now, how do you treat this patient? Right? Now, of course, you can't hasten the insulin secretion. So what you do is, you delay the delay the glucose absorption. Right? So now, remember, this is the problem, right? This is the problem. So how do you solve this problem? What you do is, you delay the glucose absorption or reduce the glucose absorption to match that of insulin, right? Okay, so now what we are doing is, we are delaying the glucose absorption so that it matches that of insulin, and this removes the hypoglycemia, right? So to illustrate this was a case which was published, right? So here they looked at, you can see without acarbose and with acarbose, and you can see the glucose values, right? So this is exactly what I told you. So here there is a big peak of glucose which is happening, right? And with acarbose this is flattening, right? Plasma glucose value. But if you see the insulin also response, you can see without acarbose there is a sharp insulin response, whereas with acarbose the insulin response is blunted and delayed. And because of this, hypoglycemia is also less. right? You can see here this patient, before this patient typically has this type of post-meal hypoglycemia, right? But after giving Acarbose, this went away, okay? So this is something very typical that you see in reactive hypoglycemia. It's a very common condition. Also same thing happens in bariatric patients. So post-bariatric patients also similar thing happens. And because of that also these post-bariatric patients, they also develop severe hypoglycemia. In fact, it's so severe, so problematic that sometimes patients want the reversal of bariatric surgery because it is too much of a problem. So overall, what I'm trying to say is Acarbose is something which prevents postprandial hypoglycemia. Not only it prevents postprandial hyperglycemia, but also prevents postprandial hypoglycemia, and hence it is a very effective drug for this situation also, right? So this is my end of my deliberation, right? Just to summarize, right? And I promised you why the brushes were there. Remember, brushes are for two reasons. One, Acarbose, you can actually put it in the mouth and chew it, right? Similar to, of course, not brush, you are not going to chew it, but the point is that, and also the brush border of the intestine, right? So Acarbose is one of my most, favorite oral antidiabetic drug that I use in my practice. Acarbose typically works by blocking the amylase and so when you chew this drug, it blocks the amylase in the oral cavity and which prevents the breakdown of the complex carbohydrates, oligosaccharides and polysaccharides. And secondly, it acts on the alpha glucosidase in the intestine, where it again does the same thing, right? So basically, it prevents it to break down into glucose, and preventing it from breaking into glucose, it delays the absorption of the drug, absorption of glucose, and hence prevents the postprandial hyperglycemia. It's a very good drug for reducing postprandial hyperglycemia and also very useful for preventing postprandial hypoglycemia also. And it's a very versatile drug. It can be used in various clinical situations. It can be used in type 2, it can be used in type 1, pancreatic diabetes, hyperglycemia in pregnancy, and various hypoglycemia postprandial conditions also it can be used, right? Typical side effects, of course, are abdominal pain, GI side effects, flatulence. These are generally the side effects, but generally these side effects occur because what happens is that you have unabsorbed all these unabsorbed carbohydrates in the intestine, and these unabsorbed carbohydrates are acted upon by the bacteria, which ultimately lead to the flatulence and other symptoms. But what happens is that when this bacteria, they eventually change, and by this change of bacteria, eventually the flatulence and etc. also reduce over a period of time. So that is something which is initially these patients will have a lot of flatulence, but that reduce over a period of time, and especially if the patient takes less carbohydrates in the diet, there is less amount of unabsorbed carbohydrate, and because of that also the flatulence also reduces, right? So that is something which is useful, right? So again, thank you for patient listening, and these are the contact details of mine, and if